if I look outside, I would also rather go skiing instead of listening here to hormonal treatment, even if Kurt Miller is speaking. But my job is to discuss with you immediate hormonal therapy. And first, best greetings from my home city, Dresden. And then let's start with the Cochrane Collaboration. And the Cochrane Collaboration in 2008 looked to progression-free survival and to all the literature. And as you can see on that slide, there is always an advantage for those having had immediate treatment. And the same was also true for complications. Now it's the opposite round. It's not tremendous, but however, if you look here, the weight is pretty high and it's significant. So in this Cochrane review, the conclusion was available information suggests that early androgen deprivation therapy reduces disease progression and complications to progression, and early androgen deprivation therapy may provide a small but statistically significant improvement in overall survival, however, only after 10 years, and there was no statistical significant difference in prostate cancer-specific survival. Verhagen and co-workers did 2 years ago in European Urology another meta-analysis. And as you can see here, there are very old trials included and will later on refer to that. And here you can see the overall survival benefit. And there was a reduction of 10% in overall survival for those patients in the complete analysis. However, those old trials from WACORC and the MRRC trial were not positive, as you have seen. So the new ones were positive. And again, showing that these patients included were locally advanced or metastatic disease almost in all those groups. And the treatment started in the deferred arm in the old trials very late. Only on progression in the WACORC trial, it was an individual decision, and in the MRC trial on request of the patient. So a certain amount of patients did not receive any treatment at all. Later on, it was more on symptomatic metastasis pain, but never in those trials on PSA response. So if you look again, those old trials did not show this difference, only the new ones, and especially the EORDC trial, showed the results. The EORDC trial showed the results referring to this reduction in overall survival. And if you look in more detail to this EORDC trial, which was published by Urs Duder, you can see that the prostate cancer mortality looks to be similar, which was something we could not really understand. However, the not prostate cancer's survival was much better under hormonal treatment. So it's very difficult, probably, to find the causes of death. And if you look to all in the deferred arm, to the survival status in the deferred arm, there was, however, in all the different mortality reasons, a trend in favor of the immediate arm. The deferred arm was worse in all. In prostate cancer, it was not really pronounced. It was only 19 versus 20%. So only very little. But who really can judge in those very ill patients what was the reason of death? That's very, very difficult to do. In total, it states that the early treatment was better than the late one. In the subgroup analysis, Studer looked and co-workers looked which patients did really profit, and these were those having had, at the time of diagnosis, a PSA above 50. And if the PSA was 8, or if the PSA was 50, there was a really difference which you can see here. So it has also probably to do something to do with risks in these patient groups. Does immediate hormonal therapy prevent progression? And Judd Mowell published in 2004 this paper that he said there is no difference if you start early with hormonal treatment and those with late. There was not a big difference for those having had late versus early. But if you look to the high-risk patients, there seems to be a difference. Those with the Gleason's 8 to 10 and those with had really a profit from the early treatment. So we have probably not only to look to PSA, maybe also the tumor biology itself is a reason to start earlier hormone treatment. After radical prostatectomy, there was also this multivariable analysis about salvage therapy, and they could clearly show that survival was improved in those patients in this huge database if salvage hormone therapy was applied early in comparison do not, and also salvage radiotherapy. All the other ones, you can see positive surgical margin, Gleason score, and PSA failure were only of minor significance. So, the other thing is, if you look to this old Messing trial regarding patients after radical prostatectomy with lymph node metastasis, and you know that this small group of patients, only 98 patients were here included, that their immediate hormonal treatment was much better than observation. And they removed between 11 and 14 lymph nodes in this group. And we also looked to our database. We have had 193 patients evaluated, and it looks quite similar at the end if you have hormonal treatment applied early. And we did also, in more than 90% of our patients, apply hormonal treatment early. So, but in the control arm in the Messing trial, the androgen deprivation therapy was only applied when recurrence was detected. There was not rising PSA a reason to really to apply a hormonal treatment. It was only metastasis, which is a problem. If you look to another, I think, very well looked at database that is, again, from Bern and Bader and Studer, and we have also people from Bern here, it showed the prostate cancer specific survival in patients having a lymph node positive disease without adjuvant hormonal treatment, and that really did an extended lymph node dissection. And these are our own data. We have 193 patients, and this is the survival. And we applied hormonal treatment early. However, in our series, we removed not 21 lymph nodes, we removed, according to the pathologist, might be some more, but not counted as well because it was not prospectively done, 14. But the survival is much better. And we looked into more detail, and also Bern did that, and they looked to patients having 1 positive lymph nodes, 2 positive, or more than 3. And you can see there was a difference if you look at 10 years. And if you superimpose our data with 1 to 2 lymph nodes, there was completely a similar result. Those patients probably did not profit from early hormone treatment. So we now not doing any more early hormone treatment in those patients having had 1 to 2 lymph nodes. However, in those having 3 or more, you can see the huge difference in cancer-specific survival between those having had early hormonal treatment and having late. It's similar if you look to PSA. If you have more tumor mass, you probably need to start early and to start not late. So another reason, which was always said, that it's problematic was cardiovascular mortality. There is a recent meta-analysis which was published last year in JAMA, looking to also a huge database of more than 4,000 patients, and they could not find any difference in cardiovascular mortality. So we have to revisit that. However, this analysis does not really prove that there was also a lower overall mortality with androgen deprivation. You can see here again significant lower mortality. However, this does not prove completely that in patients having comorbidities, that this is really the case. And we know that this has not been done in this analysis. This subgroup was never been looked at. If you look to the guideline recommendation, and I have here again the European and the German ones, and the German ones, you know, it's a multidisciplinary guideline. We'll later on speak about that. There is, and this is, I said it now in German because I think there are a lot of German here, that in symptomatic metastatic disease, there should be hormone therapy applied immediately. And if you look to the EU guidelines, you can see in M1 symptomatic patients, there is a pro-early hormonal treatment. In M1 asymptomatic 2, in N+ disease, in locally advanced M0, only in locally advanced disease treated with radiotherapy, there's a plus and minus. So if a high dose radiotherapy is applied, they say that androgen deprivation therapy is questionable. And in locally advanced asymptomatic, unfit for local definite treatment, there's also limited overall survival improvement, not related to a cancer-specific benefit. So in total, although the guidelines are pro-hormonal early hormone treatment or immediate hormonal treatment, however, not in all cases. So in summary, I think treatment at symptomatic progression is definitely too late. And especially, I think I could show to you that high-risk patients benefit from immediate therapy. And we have probably to rethink the discussion about increased cardiovascular mortality, because in big groups there is no increase. However, this has not been definitely shown for subgroups like those having really high comorbidity. Thank you very much.
We're going to go straight to Professor Miller, intermittent therapy, and then we have questions and discussion.
Ich hoffe, Sie sind damit einverstanden.
Good morning, everybody. As Nori has already mentioned, there's no real con in terms of that I'm going to talk about deferred hormonal treatment. So this situation reminds me, I think, I've known Manfred for a very long time, so we're like an old couple, you know, if they talk to each other, they really don't talk to each other. So let me just mention two things about deferred treatment.
The microphone first. I think you have to switch it on.
Oh, thanks for that. And also, it's always this practical recommendation. In any meeting, he has practical recommendations. Can you hear us? Should I tell you the story of the old couple again? No, not really. I think you got that one. So I think it's really, I mean, Manfred mentioned that in M1 disease, even if it's possible to delay androgen deprivation in asymptomatic patient, actually the reality is nobody does that. I don't know any urologist in Germany who would, if he sees a primary D2 disease, who would delay that. This is beside reality, I think. It's a different issue if you have a rising PSA or if you have low volume disease. But so I would say that's that situation when you can really defer that treatment, unless you have a very aggressive tumor. Let me go through intermittent. Pro, huh? He didn't make any cons, so how can it be pro? Let me briefly go through the history, because there's so many twists and turns in the history of androgen deprivation and also funny things. Here's Manfred. No, that's not funny. But I couldn't actually find a picture of Ferdinand Lebris. There is no picture in the internet, but I must refer to that big fish he has been talking about, you know, practically eliminating the death from prostate cancer by using complete androgen blockade. That comes from Canada, Laurie. What do you all right. So, and at the end of the day, of course, the fish is very small, and you see a very small survival advantage. That's just to see that, you know, this is a story of errors and marketing and whatever it is. So back to intermittent androgen blockade, which came up a long time ago, actually in the 90s. And actually it was Laurie who did the first paper on that with estrogens. And I didn't realize that you was the moderator, otherwise I would have mentioned it. So anyway.
Big trouble.
Because again, anyway.
Sorry, the talk's over.
Come on. Be glad that I didn't mention that paper. All right. So anyway, the whole thing was based on an experimental model, which actually did not include prostate cancer, but it was a hormone-sensitive, I think it was breast disease or something. And the idea was, keep that in mind, that we can delay the time to what we now call CRPC, if we don't use continuous, but if we use intermittent androgen blockade. So we did a study. I thought I'd show you the 3 randomized studies, which are now available. Don't look into the details here, just to see what type of patient did we include, M1 patients and N1 patients. And we can discuss the ons and offs of intermittent later. We had about 300 patients randomized, 41% were D2 disease, no difference in time to progression, which was the primary endpoint, no difference, which is probably the more important endpoint in overall survival. Better quality of life, by and large, especially general organ and sexual function for intermittent therapy, and no difference by and large in the adverse events, no matter what you look at it, especially also in cardiovascular disorders, no significant difference. 90% of the patients were about 50% of the time had no therapy. And remember, this was monthly depots. That was a long time ago. This started in 1995. And it took 70 days until testosterone was normalized. The second study has been published by Da Silva in 2009. Not so different, actually. Patient cohort, 600 patients, 3 months run-in. We had a 6-month run-in, time to progression primary endpoint. 30% were M1 disease. Remember, in our study, 40% have been M1 disease. Median PSA was 35, 38. And again, no difference in progression-free or overall survival. Here you see a little trend that continues is a bit better. On our study, it was just the other way around. Tumor-specific mortality, always hard to define who died of prostate cancer. A little bit in favor of continuous. More patients in that study died from prostate cancer in the intermittent arm. On the other hand, again, reversed if you look at cardiovascular mortality. Less side effects in the intermittent arm through all hot flashes, gynecomastia, headaches, skin complaints, whatever you look at. And counterintuitively, better quality of life in the continuous arm. Why is that? That's hard to say. Even the authors in the discussion had a hard time to explain how that happened. The only thing that was better in the EAD arm was sexual function here. And the third study, different patient group from Canada again, PSA recurrence after radical local therapy. And I think it was radiotherapy and it was prostatectomy both, if I got that correctly. Correct me if I'm wrong.
90% were radiated, 10% had surgery, then radiation,
all right.
and hormones.
So, good. And in this study, overall survival was the primary endpoint, and you see there's no difference here. And again, a similar picture as in the Da Silva study. A little bit more patients died from prostate cancer in the intermittent arm, and it was the other way around, possibly from cardiovascular disease in the other arm. But the significance in dying from prostate cancer after 7 years, disease-specific mortality after 7 years was not different in the two arms. You see the p-value on this side. In this study, as we would intuitively think, if you look at quality of life, in all the domains, it was better quality of life in the intermittent arm. And so we are at the guidelines, as Manfred already mentioned. In most of the guidelines, I already took the guidelines who actually recommend, I left out the other ones, who recommend EAB, EAU, NICE, and German guidelines now have it all in as not being experimental anymore. And I think if you look at the data, it's really, why shouldn't you use EAB? There is no survival disadvantage. I mean, look back. Our original idea was we could delay the time to CRPC. This did not happen. But there were some reports in the meantime that there could be also a disadvantage. I mean, we're talking about, remember, we're talking about lowering testosterone to 0.5 or better 0.3 or better 0.1. And we're talking about micro flushes and all that type of stuff. And this is better for the patient if you suppress testosterone continuously and better. How does that translate into no survival disadvantage in EAB? I don't know. I really don't know. But if you look at the data from 3 randomized studies, there is no survival disadvantage. It's 2 to 1 for a better quality of life. You have less cardiovascular side effects without going into the detailed discussion. What is the cardiovascular problem of continuous androgen deprivation? We have no information on osteoporosis, actually. So we can just speculate. If you do intermittent therapy, you have less problems with bone density, and there's some cost savings. Thank you for your attention.
So we'll open the floor to questions and comments, but just to throw out a point, as Kurt mentioned, really these are 2 separate issues, the timing of therapy and the use of intermittent therapy. And maybe you could just comment about, is there a consensus about what the trigger should be for initiating intermittent therapy? Kurt?
Excuse me?
I'm sorry. The question is...
Sorry. I need to have some schmooze with Manfred now.
The two of you can have some private time later on.
Yeah, we are going 3 hours with the same car, you know, we have a lot of time.
What should the trigger, in your opinion, be for initiating intermittent therapy, given, do you agree with Manfred's view that early therapy is better specifically with respect to PSA trigger?
You mean in what particular situation?
Rising PSA failure. PSA failure.
Actually, I don't know. So it's really, I mean, in rising PSA, practically, what do I do in that situation? I tend to use anti-androgens rather than LHRH antagonists, because my impression is, if you look at side effects again, this has a lower side effect profiles, and we have no clue that this is worse in terms of progression-free survival, whatever survival we look at, if you compare it with LHRH agonists. The only study Manfred has mentioned it is from Judd Moe, and he took, and this is pretty arbitrarily, 5 PSA of 5. And there was no difference in the low Gleason score, and there was only difference in the high Gleason score. So that's all the evidence we have, to my knowledge. And so I mean, if you have a fast doubling time, if the patient has had a Gleason 9 tumor, it's an easy decision. But if it's a Gleason 6 and a low rising PSA, to be honest, I'm seldom on it. But, you know, I even start with a 5-alpha reductase inhibitor. And about 30% of the patient respond to that. And then I make a step up to anti-androgen, and then I make a step up. Because I think it's more psychology.
I personally think that we will have in maybe 2 to 3 years a complete change how we treat hormonal patients, because we have now new compounds. And one I'm really very interested in is MDB 3100. This is the anti-androgen. And this, if it's really working like it looks now, then it's an ideal drug for the early treatment. And also an ideal drug if we want to use it for intermittent treatment. Because the problem of intermittent here is, and you said it already, is that only around half of the patients to really recover regarding their testosterone. The other ones stay really low. That is one problem. So we are not really talking about intermittent regarding testosterone suppression in almost half of the patients. So I personally think that since we have also this new data showing that really extensive hormonal treatment has better results. Maybe we have better apoptotic results in those treating early. So I think in 5 years or in 3 years, probably we change everything what we now know.
Except, first of all, just to emphasize, we have absolutely no data on MDV 3100 as monotherapy.
Yes.
Zero.
Yeah.
So that's a bit of an extrapolation.
Well, but 5 years from now,
He can speculate 5 years from now. Right? That's,
Peter?
well, I can speculate too, yeah. I would agree.
Manfred, just a quick question. The definition of early androgen deprivation, if you could make that definition, because nobody waits till you have symptoms any longer. So many of the data that you showed are for very delayed therapy. My question is, for the patient with a relatively long doubling time, 2 years, 3 years, who has a recurrence, PSA recurrence following radical prostatectomy, are you putting people on hormone therapy immediately, or do you think it's wrong to delay that patient 4, 5, 6 years before their PSA maybe rises to 20 or 30? Because I look at the trade-off between the osteoporosis and all the side effects of anti-androgen therapy, that you can delay that for several years in the patient with relatively low-grade disease with a very long doubling time. I mean, technically what you've said is everybody gets early androgen deprivation. I'd like you to extrapolate on that.
you know, first it was a little bit of pro-discussion. I was pro-immediate, that was if you read in the program. And I said it already, and I gave already the hints, that it should be risk assessed. And that is a conclusion of probably our talk, and Kurt will completely agree. And I would not treat a patient, as I already said, who has a high comorbidity with hormonal treatment early, because those patients may die from other disease. That's the first, that's a patient. And the second thing is a tumor. And if we have a low-risk tumor with a long doubling time of more than 2 years, then there is absolutely no reason to start hormonal treatment early. That is completely clear. But this is an individual decision. The patient has to be looked at, and also the tumor. And it's not so easy to say now, I start at that point, because you have to take both together. And therefore, we are the experts in this field, and not everybody should start such a treatment who does not really know the pitfalls and the positive effects.
But, you know, the other point here, the one paper that you referred to, EORTC 30891, is the one data set that does give a PSA threshold for introducing hormonal therapy
50.
early versus delayed, and it's 50, although that's for men over 70.
Yes,
and
75.
And 20 for younger men, but it's still much higher than most people use as a PSA threshold. And that was primary hormonal therapy. So the Judd-Moule data that Kurt referred to, but is in post-radical prostatectomy, which is the scenario, but that was a retrospective study, non-randomized. So, I mean, the EORTC data to me is very relevant to this, and that should be the guide. Like to me, the best data is if you're gonna pick a PSA threshold for initiating therapy, it should be in the range of 20 to 40 or 50. You know, supported by that study, and there's really no other data out there.
But this is, again, you transfer data from one population to the other population. So this, I mean, you could do that, and probably you're right, but I could argue, well, how do you choose 20? I say 35. And everybody could say it's right. I mean, the thing we agree upon probably is, as Peter, you can delay it. And the problem is more on the psychology side than on the medical side, or that the patient really dies from prostate cancer. That's the point.
The problem is also if you compare those patients having the prostate in and those patients having the prostate out, that's also a big difference which you have to be aware of. So for me, you have to know the literature like you know it, and Peter knows it, and I think all now know it here. And then you have to do your decision with the patient, also seeing the patient, how fit he is, what he expects from his life, if he wants to go to the Himalaya or not. That is also a reason to stop hormonal treatment. So I have patients doing that. So it's really it's for me more or less not a yes or no. It's more individual.
Can I, just one more practical question for Kurt about intermittent therapy. Based on your review of the topic, what do you think the induction period should be in clinical practice, and what should the guideline for restarting therapy?
Good question again. There are some arguments for that. Use it as long as you really have a solid nadir in your PSA, like then you see what's going on with the patient. And this might, we in all the trials we had different run-in periods actually. So probably half a year or 8 months is a nice try. But in daily practice, you can. I also do. I have patients that just get one shot, and then I stop it again. And it's not that I have the impression this is evidence-based again, that it's disadvantage for the patient. But if you try to put it on a rational base, do it for 6 or 8 months, and then discontinue. And to go in again, this depends on what type of patients we're talking about. Are we talking about rising PSA patients, or are we talking about metastasized patients? That might be totally different. In rising PSA, you sometimes get the PSA down to 0 point nothing again. And then you can say, well, depending on the doubling time, go in again at 4. Why 4? I don't know. Because I just came to my mind. So we have no data on that. We have no comparable data, so it's purely, intuition-driven. That's it.
I was really talking about the PSA failure population. The metastatic population, probably most of you know the SWOG trial in metastatic disease was started in 1993, almost 20 years ago, is going to be reported for the first time at ASCO this year. And I have heard the investigators said, be prepared for a surprise. So it's going to be interesting to see what that shows.
The problem, I see the biggest problem is when to start. Because at the time you start, you are putting the trigger. And a lot of those patients, you start, and even they are intermittent, they will not recover at all. So the starting point is the most important one. And it's not intermittent or continuous. That is my feeling, and this has to be known. If you start, around 50% never will recover as they had been before, at least.
Okay, great.
You're ready. Yeah.
Okay, so we proceed with